I chose to complete my poster on pulmonary embolisms. Working in the cardiac intensive care unit, I see patients with this disease process quite often. To begin, pulmonary embolisms are thrombi that often have developed in the pelvic or leg vein and travel to the lungs, disrupting blood flow to the pulmonary arteries. Approximately 39 to 115 per 1,000 people are affected by pulmonary embolisms annually. It was also noted to affect males more than females. Risk factors can either be genetic or acquired. Genetic risk factors include prothrombin gene mutation, thrombophilia, protein C deficiency, hyperhosterotomy, and protein S deficiency. Acquired risk factors include prolonged immobilization, malignancy, obesity, recent or orthopedic surgery, use of oral contraceptive pills, pregnancy, and cigarette smoking. When a clot breaks off and enters the pulmonary system, it's called a pulmonary embolism. The larger emboli often block blood flow to the main pulmonary artery, whereas the small emboli often block the peripheral arteries. Due to these blocked areas, impaired gas exchange occurs, leading to hypoxia and dead space ventilation. Pulmonary vascular resistance is increased, which causes increase in the right ventricular afterload and ultimately can cause RV dilation, resulting in hemodynamic instability. Symptoms of PE include dyspnea, cough, hemoptysis, pleuritic chest pain, presyncope or syncope. Signs of PE include tachypnea, tachycardia, decreased breath sounds, elevated neck veins, right-sided gallop, and cyanosis. When trying to diagnose PE, there are a multitude of labs and tests to look at. If a patient has unexplained hypoxemia, with a normal chest x-ray, an ABG could be obtained. With a PE, the ABG will often show respiratory alkalosis and hypocapnia. An elevated BNP could also be indicative of a PE due to the effects a PE has on the right side of the heart. Another marker for RV dysfunction caused by a PE is an elevated troponin. An echocardiogram can show how affected the right side of the heart is from a PE. ECG findings can show tachycardia, non-specific ST segment T-wave changes, and a new right bundle in patients with a PE. D-dimer test indicates an embolotic process in the body and is elevated in patients with a PE. A CTPA provided the most visualization for a diagnosis. Two assessment tools include the Geneva and Wells score, which determine the probability of a patient having a PE. Clinical practice guidelines differ depending on the severity of pulmonary embolism. If it is uncomplicated, home treatment is recommended with an oral DOAC. If hemodynamic compromise is present, it is recommended to treat in the hospital with thrombolytic therapy, then transition to an oral DOAC. In terms of pharmacological management, I chose apixaban, an oral anticoagulant that has been approved since 2014 for the use with pulmonary embolisms. Apixaban inhibits factor XA and prothrombinase. It's mainly metabolized by the enzyme CYP3A4. Dosing initially starts with 10 milligrams twice a day for 7 days, then 5 milligrams twice a day for 3 to 6 months, then 5 to 2.5 milligrams twice a day indefinitely if that's indicated. The most common side effect is bleeding in 2 to 4% of patients. Other less common side effects include nausea, hematuria, hypermenorrhea, anemia, bruises, and hematoma. Patients on Eliquis had a 67% less chance of reoccurrence of a DVT and PE. When taking apixaban, the risk of bleeding is increased when administered with other agents such as aspirin, NSAIDs, or heparin. It's important to educate patients on the increased risk of bleeding. Thankfully, there is no additional monitoring when taking this drug in terms of lab work. To determine prognosis of those diagnosed with PE, the PESI score is utilized. 30-day mortality risk is 1% for those with a PESI score of 0. If the PESI score is 1 or above, 30-day mortality risk increases to 10.9%. I have here listed some patient education resources. In addition, some current evidence-based practice is those diagnosed with pulmonary embolisms need to be on an oral anticoagulant. The recommended timing is at least 3 months, up to 6 months, and extended even further if the risk of reoccurrence is high. Ultimately, though, once the anticoagulant is stopped, they do not eliminate the recurrence of a PE. I want to thank everybody for listening to my poster presentation.